Hello, everyone, and welcome to our module on treatment of TIA and stroke. Let's start by talking about stroke, which is also sometimes referred to as a cerebrovascular accident or a CVA. And some people think of a stroke as a brain attack because it shares many similarities to what happens in the heart when a patient has a heart attack. It originally was named stroke because patients sometimes collapsed when they had this condition and they appeared struck down, and that's why it was called a stroke. But basically, a stroke refers to the sudden loss of neurologic function, and it can be caused either by ischemia, meaning decreased blood flow to the central nervous system, or by hemorrhage within the central nervous system. So there are two major subtypes of stroke. One is ischemic stroke, depicted here with a blood clot cutting off blood flow to the brain. The other is a hemorrhagic stroke, depicted here with bleeding from a blood vessel that supplies the brain. So a TIA is a transient ischemic attack, and it's basically a miniature version of a stroke. And we used to distinguish stroke from TIA based on time. If a patient had the sudden onset of neurologic symptoms that resolved within 24 hours, then we said that that patient had a TIA. If the symptoms resolved after 24 hours or persisted, then we said they had a stroke. The new definition is biologic. It's based on identification of tissue injury, usually by MRI. So if you do an MRI in a patient who had transient neuro symptoms that resolved and there's no evidence of permanent tissue injury, then we call that a TIA. If, on the other hand, there is evidence of permanent tissue injury, then we call that a stroke, even if the symptoms resolved quickly within the first few hours after their onset. And as I said, this is usually sorted out by MRI. There are a number of different findings that identify brain damage, and when you see those, that's a stroke. If they're absent, then that's a TIA. So let's start by focusing on stroke, and let's talk about the different etiologies of stroke. So about 80% of the time, strokes are ischemic, and by this I mean they're caused by insufficient blood flow to the brain. This can happen by a couple of different mechanisms. First of all, there can be thrombosis, meaning a blood clot in a vessel that supplies brain tissue that cuts off blood flow. There can also be embolism. So for example, a blood clot in the heart can break off and travel to the brain and obstruct a vessel and cut off blood flow to the brain. That will cause an ischemic stroke. You can also have an ischemic stroke from hypoperfusion. So for example, patients who have a cardiac arrest, their heart stops pumping blood and they underperfuse the brain, and that can lead to ischemic damage. When patients have an ischemic stroke, the symptoms often develop slowly over hours. It takes time for the dysfunction of the central nervous system to set in, so the patient will notice symptoms that begin suddenly and then slowly get worse over a couple of hours as there's less and less blood flow to the tissue in the brain. About 20% of the time, however, strokes are hemorrhagic. This means there's bleeding into the brain. And these strokes tend to have a more sudden onset, so patients can go from completely normal to very abnormal over the course of just a few seconds or a minute, and that's at the time when the bleeding develops. When patients present with the sudden onset of neurologic symptoms, the best first test is usually a non-contrast head CT, provided the patient is stable. When you rotate through the emergency department and patients come in with new onset weakness or vision, or trouble speaking, or whatever neurosymptom you can imagine, usually they will be sent urgently for a non-contrast head CT. And that's because this is quick and can be done in most emergency rooms, and also it's able to easily distinguish ischemic from hemorrhagic stroke in most cases. Now, a diffusion-weighted MRI is the most accurate test to identify stroke, but this takes time to perform, and so it's not usually done initially until the patient's symptoms have been sorted out and treatment has been begun. And as I said, the reason we always want to do a head CT first is because it differentiates ischemic from hemorrhagic stroke, and this has important implications for management of the patient, which we'll talk about in a second. So in patients who have had an ischemic stroke, their non-contrast head CT is often normal for the first 6 hours. Later, as the tissue develops necrosis from ischemia, it can become dark on non-contrast head CT. And so if you look at these two images on the screen here, and you look at this one on the left, there is this dark circle here in the cerebellum. That's what you can see several hours after a patient has had an ischemic stroke. It's not bright white. That's what blood looks like. It's dark. And once again, remember that these non-contrast head CTs are usually normal initially. It takes time for the tissue to change and become dark like what you see in this image. This image on the slide is something you might see in someone who had an ischemic stroke 12 or 24 hours ago. In contrast, when patients have a hemorrhagic stroke acutely, meaning very soon after symptoms develop, you will see white areas of blood on a non-contrast head CT. And that's what's shown in this image over here on the right. This is another non-contrast head CT, and this white region here indicates bleeding in the brain. And this is very important to identify early on clinically because one of the major treatments for stroke is thrombolysis, and that is contraindicated when you see blood in the brain like this. Thrombolysis administered to a patient with a hemorrhagic stroke can be fatal because it will make the bleeding worse. Okay, so that's a nice segue into the acute management of stroke. So as I said, a patient presents with new onset neurosymptoms. Usually the first thing that's done if the patient is stable is to get a non-contrast head CT. This can be done very quickly in most emergency rooms. If the stroke is ischemic, then you have to consider thrombolysis. We'll talk about this in a minute. This is a very effective therapy when it's administered early, meaning in the first few hours after an ischemic stroke develops. On the other hand, if the head CT shows a hemorrhagic stroke, then thrombolysis is contraindicated. In this situation, what you usually do is you reduce the blood pressure if the patient is hypertensive, because many patients with hemorrhagic stroke are hypertensive when they initially present. If the patient is taking any anticoagulants like apixaban or warfarin, you want to reverse those drugs so the bleeding doesn't progress. And then finally, if the bleeding is massive and there's a risk of herniation of brain tissue, then surgery is sometimes required in cases of hemorrhagic stroke. Importantly, though, and it's high yield to know this for your board exams, especially if you're not used to managing stroke patients in the ER, there's generally no benefit to other drugs besides thrombolysis in acute stroke. So things like heparin, warfarin, antiplatelet agents, there's generally no benefit to these drugs. They're contraindicated in patients who have hemorrhage, and there's no benefit to giving these drugs together with thrombolysis. Basically, the only time you'll use any of these drugs is if a patient has an ischemic stroke and they're not a candidate for thrombolytics for some reason. In those cases, we will sometimes give aspirin. But outside of this situation, we usually don't use these drugs in the acute management of stroke. They do have some role that we'll talk about later for preventing recurrent strokes, but in the emergency room in a patient with new onset symptoms, usually heparin, warfarin, other antiplatelet drugs besides aspirin, these usually aren't used. Okay, so now let's talk about thrombolysis. So thrombolysis involves administering to a patient with an ischemic stroke either intravenous TPA, which is called alteplase, or TNK, which is called tenecteplase. And I talk about these drugs in more detail in videos in the hematology section. But by way of review, what these drugs do is they activate plasminogen. They're called plasminogen activators, and they convert plasminogen to plasmin, and plasmin can cleave thrombin and fibrin, and this is basically breaking up clots because clots are made up of thrombin and fibrin. So in an ischemic stroke where the clot is obstructing flow to the brain, these drugs will break up the clot and that can restore blood flow. These drugs increase the prothrombin time and the PTT. I talk about these tests in the hematology section. They are tests of how quickly clots form in the body. So obviously, the presence of a drug that breaks up clot is going to prolong the time it takes for clots to form. They will have no effect on platelets. These drugs don't lower the platelet count. And importantly, clinical studies have shown that there must have been less than 4.5 hours since the patient was last normal from a neurologic sense. That's the only window in which these drugs are effective. So a huge element of management of possible acute stroke is quickly identifying whether the patient has an ischemic or hemorrhagic stroke, and then if they are within this 4.5-hour window, determining whether they are a candidate for one of these two drugs, which are potentially life-saving and can greatly improve neurofunction after a stroke. So along those lines, shown on this slide are the contraindications to thrombolysis. If any of these things are present, then the patient cannot receive thrombolytic drugs because the risk of intracranial bleeding is too high if these items are present. And so the major elements of managing patients with acute stroke is first getting a head CT to determine that it's an ischemic and not hemorrhagic stroke, then determining the time window, is that patient within 4.5 hours of the onset of symptoms, and then finally assessing the patient for any of these things here, because you can't have any of these things present if you're going to give thrombolytic drugs. So all of these items on this slide are here because they've been borne out in clinical trials as predicting risk of bleeding after thrombolytic drugs. So stroke or head trauma in the past 3 months is fairly straightforward. That raises the risk of intracranial bleeding. If the patient has internal bleeding or trauma, that's obviously bad and you don't want to give them thrombolytic drugs. Blood pressure can't be too high, the INR can't be elevated, and they can't be taking DOACs, which are drugs like apixaban and dabigatran. Their platelets can't be low, they can't have an elevated PTT, they can't have a low glucose, and finally, they can't have any history of intracranial bleed in the past, because if anything like this is present, then the risk of intracranial bleeding with thrombolytics is too high to give the drugs. Besides thrombolysis using drugs, there's another way to restore blood flow to the brain in ischemic stroke, and that's a surgical procedure called a thrombectomy. This is used in specific cases of ischemic stroke only at centers that are capable of doing this procedure very quickly. This is only done when patients have a large vessel occlusion. Ideally, it's done when the patient's stroke has occurred within the last 6 hours, although it is sometimes done up to 24 hours after stroke onset. And you can sometimes do it together with thrombolysis. Sometimes it's done without thrombolysis. And so if you look at this image on the slide here, this is an angiogram of the brain. And notice that over here on this side, we've got a vessel that comes down all the way over here and gives off lots of little branches. But on this side, at the end of the arrow, the vessel stops. That means contrast can't go beyond this point at the tip of the arrow. And that's because there's a thrombus right here. So this is a case where thrombectomy could be performed. There are catheters that can be threaded into these vessels, and they can suck out the clot, and that can restore blood flow on this side so that the blood vessels on this side begin to look just like the ones over here. After a patient has had one stroke, they're at risk for having another stroke. So there are important things that are done post-stroke to try and manage the patient and prevent a second or additional stroke from occurring. One of these is antiplatelet therapy. So in ischemic stroke, aspirin alone or clopidogrel, if the patient is aspirin allergic, is almost always administered lifelong to try and reduce the risk of another stroke. Sometimes patients are even given dual antiplatelet therapy with aspirin and clopidogrel for a short duration. If you do a neurology rotation, you'll talk about all the different clinical studies comparing these different strategies. And there are certain patients in certain situations where aspirin alone is used or where dual antiplatelet therapy is used. This is not something you need to know for step one. And then beyond this, high-intensity statin therapy, usually with atorvastatin, is given. High intensity means a high dose, usually 80 milligrams of atorvastatin or a high dose of another statin drug. And the idea here is that statin drugs have been shown to stabilize blood vessels with atherosclerosis. And so giving them to all patients who've had a stroke reduces the risk of having additional strokes. There's some testing that's usually done after a patient has had a stroke, and I've summarized that on this slide. So first of all, an EKG at least, or sometimes telemetry, which means long-term monitoring of the heart rhythm, is done. And the idea here is to look for atrial fibrillation, because we'll talk about this in a minute, but if a patient has atrial fibrillation and they've had a stroke, then they need to take a blood thinner like warfarin or some other anticoagulant to prevent additional strokes. An echocardiogram is also often done in patients who've had a stroke. The idea here is to look for the so-called source of embolism. So some patients have a thrombus in their left ventricle. This can be a source of an embolus to the brain that causes an ischemic stroke. You can also sometimes identify a patent foramen ovale, which I talk about in videos in the cardiology section, but this is basically a hole connecting the left and right atrium, and sometimes a clot in the leg can travel through one of these holes and cause an ischemic stroke. And then finally, some evaluation of the carotid arteries is usually done in patients who've had an ischemic stroke. This can be a CT angiogram of the head or an ultrasound. And the idea is to identify significant stenosis of the internal carotid artery. There are clinical studies that show if the degree of stenosis is 70% or greater, then surgery may be beneficial to try and treat the internal carotid artery and eliminate this stenosis, either with a stent or a surgical endarterectomy. Determining who's a candidate for a surgery and who is not is an advanced thing that you don't need to know for step one, but you should be aware that evaluating the carotid arteries for a stenosis of the internal carotid artery is something that's commonly done in post-stroke management. Okay, let's talk about stroke in patients who have atrial fibrillation. So as I just said, in a patient who's had a stroke, there's almost always an evaluation performed for atrial fibrillation, at least an EKG, and sometimes long-term monitoring of the heart rhythm with telemetry. And the idea here is that if a patient has had a stroke and they have atrial fibrillation, then they need to take an anticoagulant drug like warfarin or apixaban or something else. We'll talk about some of these in just a second. Sometimes patients who have atrial fibrillation who haven't had a stroke, we will put them on anticoagulation to prevent a first stroke. And the way we determine who needs anticoagulation among all the patients with AFib is by using what's known as the CHAD-VAS score. So the CHAD-VAS score is a point system, and it assigns points to the patient based on their clinical history. And if their score is higher than 2, then they need to receive anticoagulation with warfarin or some other drug. If their score is 0 or 1, then they don't need to receive anticoagulation. These patients are tricky to manage. They are usually treated with either aspirin or no anticoagulation at all. And so shown on this slide are the elements of the CHAD-VAS score. Now, you don't need to memorize these elements and the points associated with them, but you should be aware that each of these items listed here significantly increases the risk of stroke in a patient with AFib. That's why they're elements of this score. So patients who have CHF have a much higher risk of having a stroke if they have AFib. So that's a point. Same thing for patients with hypertension or diabetes. Those each give a point because patients with these conditions have a higher risk of having stroke when they have AFib. If the patient's already had a stroke and they have AFib, that's 2 points. And as you can see down here, that means they're getting anticoagulation. So as I've already talked about, any patient who has AFib and who has a stroke by the CHA2DS2-VASc score needs to receive anticoagulation drugs. Female sex is 1 point, age 65 to 75 is a point, age over 75 is 2 points. Finally, a history of vascular disease like peripheral vascular disease or carotid atherosclerosis, this is also a point. So you'll see this done in outpatient settings all the time. Many patients have atrial fibrillation but have not yet had a stroke, and so the major management decision is whether or not to recommend anticoagulation. And you do that through the CHA2DS2-VASc score. You total up the points. If it's 2 or greater, then they need anticoagulation. So that's a nice segue into talking about the anticoagulant drugs we use in patients who have atrial fibrillation to reduce their risk of stroke. So the old standard when I was in training was warfarin, which is a drug that I talk about in the hematology section at length. Problem with warfarin is that you have to routinely do blood tests to check the INR. The goal INR in a patient on warfarin is 2 to 3, and it goes up and down based on the patient's diet, especially how much vitamin K they take in their diet. And so warfarin has basically fallen away and is not used that much anymore because we have new drugs that don't require blood tests to monitor the INR. The new classes of drugs that are used are the factor X inhibitors and the direct thrombin inhibitors. There are 3 factor X inhibitors, rivaroxaban, apixaban, and edoxaban, and there's 1 direct thrombin inhibitor, dabigatran. And so these are the drugs you'll mostly see used nowadays, not warfarin, for anticoagulation in patients who have atrial fibrillation for the prevention of stroke. And then finally, an important point clinically, I don't know that this will come up on your step 1 exam, but you should know this clinically. Whether the patient has AFib that persists or whether they go out of AFib and back into sinus rhythm, they still have to take anticoagulation. That's because the clinical studies have borne this out many, many times that the risk of stroke persists even if the AFib resolves and goes away. So if the patient has had AFib, even if they only had it for a day and then it went away, if they have risk factors for stroke and a high CHA2DS2-VASc score, then they need to receive anticoagulation drugs to prevent stroke. I'll finish this video with 2 slides on TIA. So the thing to know about TIAs is that they're basically warning signs of strokes. Patients who have had a TIA are at very high risk of having a subsequent stroke, especially in the first 48 hours after the TIA. There is a scoring system used to predict the 2-day short-term risk of developing a stroke. It's called the ABCD2 score. These are the elements of that score right here. It's another point system. You total up the points. If the points are 0 to 3, that's a low risk of a subsequent stroke. If the points are 6 to 7, that's a high risk. 4 to 5 is a moderate risk. And once again, memorizing this scoring system is fairly low yield, but you should be familiar with the elements of this scoring system because all these things predict a higher risk of stroke compared to patients who don't have these things. So older patients who've had a TIA are at higher risk of stroke. Hopefully that's fairly obvious and makes sense to you. In general, older patients are at higher risk of stroke, and especially those who've had a TIA. If the blood pressure is elevated when they present with their TIA, this is a risk factor. Certain clinical features are high risk of subsequent stroke. Unilateral weakness suggests a big area of ischemia during the TIA. Same thing is true if there's speech disturbance without weakness. The duration of symptoms is important. Longer duration is higher risk than shorter duration. And then finally, diabetes is an independent predictor of a higher risk of stroke. So how do we manage patients who've had a TIA? These patients aren't going to get thrombolysis because they don't have ongoing ischemia. Their symptoms have resolved. First of all, they almost always get an EKG for the same reasons we almost always do an EKG in patients with stroke. That's because we want to know if they have atrial fibrillation. And if they do have atrial fibrillation, they're going to need treatment with anticoagulation to prevent strokes. For patients who don't have any evidence of atrial fibrillation, those patients are usually given aspirin because it reduces the risk of subsequent stroke. If they're allergic to aspirin, they can receive clopidogrel. And then beyond these things, these patients get a high-intensity statin, just like patients with stroke. There's often hypertension present in patients who have TIAs, so you want to control the blood pressure with antihypertensives. If they have any evidence of diabetes or hyperglycemia, that needs to be controlled. And then finally, lifestyle modification is important, especially smoking cessation. But beyond this, dietary guidelines and exercise, all these things are really important in patients who had a TIA so that they don't go on to develop a stroke and permanent neurologic dysfunction. And that concludes our module on treatment of TIA and stroke.